Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is about neovascular glaucoma. Neovascular glaucoma is basically a type of glaucoma in which new vessels are found on the anterior segment, especially on the iris and in the anterior chamber angle, and this leads to the increased intraocular pressure. Dr. Coates was the first person in 1960 who defined this type of glaucoma in a patient with central retinal vein occlusion. It has different names like hemorrhagic glaucoma, thrombotic, congestive glaucoma, or rubeotic glaucoma. But whatever the name is, the basic pathology is retinal ischemia. Non-perfusion of the retina, which leads to the production of vascular endothelial growth factors, and these growth factors ultimately induce new vascularization in the eye, and these new vessels are the main culprit which lead to the increased intraocular pressure. If we talk about different causes of neovascular glaucoma, three main causes make up almost 75% of the cases. These are proliferative diabetic retinopathy, advanced stages, and along with it ischemic central retinal vein occlusion and ocular ischemic syndrome. These are covering the main contribution because of these three reasons. And if we talk other reasons, they may be because of inflammatory conditions like uveitis, sometimes trauma, Eales disease, retinal vasculitis, chronic retinal detachment, chronic choroidal melanoma, or retinal blastoma. Whatever the reason is over there, we can say major causes or these minor causes for the neovascular glaucoma. The reason is retinal ischemia. So if we talk about the ischemic central retinal vein occlusion, it has been studied that up to 60% of patients can develop this type of the glaucoma, while in diabetic retinopathy, especially proliferative diabetic retinopathy patients, we have also high and substantial number of patients they can develop this thing. While if we talk about ocular ischemic syndrome can affect both the anterior segment and the posterior segment, but usually it is the anterior segment ischemia which contributes to this type. So, severe carotid artery occlusion and diabetic retinopathies also have strong associations in ocular ischemic syndrome. So these patients need to be monitored regularly for any such complication. If we talk about the common angiogenic factors are vascular endothelial growth factors. We have insulin-like growth factors, tumor necrosis factor in the body, which are stimulating the production of the new vessels throughout the body along with the inflammatory cytokines. In response to this, there are anti-VEGFs also produced from the body, and the common anti-VEGFs we can say is transforming growth factors, thrombospondin and somatostatins. So this is the balance is maintained in normal healthy human body, but whenever this balance is disturbed, for example, as I mentioned, retinal ischemia, there is proliferation of these VEGFs. So what these VEGFs do? These basically cause the new vessels proliferation by the mechanism of they basically lead to the new endothelial cells migration over there. They cause it. They are produced from the Muller cells, retinal pigment epithelium, pericytes, ganglion cells, and even they are also produced from the non-pigmented ciliary epithelium. So all these places where they are produced, and they basically increase the, VEGF is a vasopermeability factor, and they cause the migration of endothelial cells. And number three, they also cause leukocytes adhesion over there. So all these things ultimately lead to the breakage of the blood-retinal barrier. Yes, blood-retinal barrier is compromised. Secondly, when these VEGFs come over there in anterior segment, They cause proliferation of the blood vessels on the iris. These grow up into the antechamber angle also vessels, and over there they block the trabecular meshwork, and there is a fibrosis element. Ultimately the angle is closed. So this is basically the sequence, and it has been documented also that the vascular endothelial growth factors from anterior segment, they also migrate to the posterior segment of the eye, especially in the patients who have undergone vitrectomy or in whom the lens has been removed. So even they move back from the front. As I mentioned, non-pigmented ciliary epithelium produces, they go back and they also induce. So this is a vicious cycle going over there until we do timely intervention to control these things. This is a slide where I want you to please have a look at how these new vessels are formed over there. And these are shown in the white and blue arrows over there. And here you can see the blood over there, and there's a single layer of endothelial cells. These blood vessels are very fragile. They can bleed quite easily, and they can lead to the hemorrhages over there. Yes, these are the new blood vessels which are formed over there, shown on the microscopic level. This is the flow chart which will explain you how these things happen. It is clearly mentioning the retinal hypoxia. Retinal hypoxia and ischemia is basically leading to the high concentration of the pathogenic factors, angiogenic factors. All these are mentioned. VEGF produced from the Muller cells, as I mentioned, and other IGF, 1, 2, FGF, PDGF, all these are leading to ultimately to the, I mentioned, endothelial cells migration, reticulocyte adhesions, and it is a beautiful diagram and flow chart which will explain you the different steps, how they are formed and how they ultimately these vessels cause contraction and the closure of the anterior chamber angle. So neovascular glaucoma, basically, as I mentioned, the ischemia of the optic nerve and the retina, these things are the main reasons which are happening over there. So it led to the scientists to go for that the perfusion pressure and ocular blood flow, these are two important factors which also contribute to the development and progression of neovascular glaucoma. The ocular blood flow is basically more like experimental thing which is being carried out by different techniques. But if we talk about the perfusion pressure, it can be calculated by mean blood pressure minus intraocular pressure. So it is believed that if the patient has high intraocular pressure and low blood pressure, these things can decrease the blood flow to the retina and cause ultimately the hypoxia. So it is better to be in touch with medical specialists who are managing the patients, that better these patients do not have nocturnal decreased blood pressure. The medicines should be like this, that it should not make decreased blood pressure at the night, so that the perfusion pressure of the eye doesn't get disturbed, because if it gets decreased, the blood supply is getting compromised over there. So these things should be kept in mind. The systolic blood pressure should not be too much decreased. Yeah, that's a very important point. So how we can see these blood vessels? These blood vessels can be seen on the slit lamp routine examination, but in these patients a gonioscopy is mandatory. I mean, because these basically cross the scleral spur, and once they cross the scleral spur, branch and arborize over the trabecular meshwork. So sometimes these vessels may initially grow in the angle prior to you can visualize them in the pupillary margin. So that's why gonioscopy is something very important which should be done in such patients to find out these presence of these blood vessels. So if we talk about the classification of neovascularization in anterior segment, this Wies and Gold classification is very beneficial in this aspect. Especially if we talk about the grade 1, it is mentioned over there that less than 2 quadrants of pupillary zone are affected, while the angle vessels cross scleral spur and they ramify on the trabecular meshwork less than 2 quadrants. I mean, the less than 2 quadrants of the trabecular meshwork over there branches can be found in the grade 1. Then he actually in grade 2 and 3 he further explains that new vessels may occupy more than 2 quadrants of iris, while in grade 3, if we talk about the NVI, they are covering ciliary zone and or ectropion UV with 1 to 3 quadrants. So this intensity keeps on growing in this V's and gold classification. Ultimately in grade 4, anti-segment new vascularization, surface new vessels are present at ciliary zone and or there is ectropion UV and more than 3 quadrants are involved, while peripheral anterior synecdoche are also involving more than or equal to 3 quadrants. So this is the last stage where the things are really deteriorating. So this classification is very beneficial for evaluation and monitoring the treatment and especially planning the management plan. Very beneficial. So if we talk about the different stages of neovascular glaucoma, we can say there is one stage which we call pre-glaucoma phase, rubeosis iridis. Just tiny blood vessels are there over on the iris which have developed over there at the pupillary margin, and they less commonly at the angle are also present and cross into the scleral spur to arborize in the trabecular meshwork. And these on gonoscopy the angles are usually open and IOP is normal in stage and the prognosis is very good. If we talk the second stage, that is the secondary open angle glaucoma. In this stage, the development of fibrovascular membrane develops on the anterior surface, membrane on the anterior surface of the iris and angle, but the angle is still open, and this open angle, this membrane, fibrovascular membrane, starts blocking the trabecular meshwork and obstructs the outflow of aqueous humor. NVIs are present, and in gonoscopy if you do, that's why I say that gonoscopy is very important in diagnosis of these things, because angles are open and NVAs may or may not still be visible, but it should be done, and the prognosis is still good. Although the pressure is raised, with timely intervention things can be managed. But after this, once the things go into the secondary angle closure glaucoma, then things becomes very difficult, because the fibrovascular membrane in the angle it starts contracting and pulls the iris over the trabecular meshwork, and it forms the peripheral anterior synecdoche. Basically these are formed, and then you will also see the prominent ectropion UV. Angles are closed. You cannot see the NVAs over there. Intraocular pressure is raised and the prognosis is very guarded, and patient is in severe pain when he comes in these stages. So these are the 3 stages. One is the pre-glaucoma, the second is open angle glaucoma, and the third is the secondary angle closure glaucoma. These are further subsidiary branches of the, we can say, of the neovascular glaucoma. So the management principles are 3: to control the ischemia, to control inflammation, and to control the intraocular pressure. How to control the ischemia? These patients need PRP. Reason is there is ischemia, vascular endothelial growth factors are being released which are causing main problem. So it's better to do as early as possible PRP of the retina. Usually 1200 to 1500 laser burns are sufficient, but they should be done in 2 to 3 sessions. Although it is an emergency, but 2 to 3 sessions are usually sufficient. Number 2, if the media is not clear and we cannot do this PRP, in these conditions we can go for the anterior retinal cryo plus cyclophotocoagulation. That is anterior retinal cryo with anti-VEGFs. This can be tried when the media is not clear. Vitrectomy can also be combined with intravitreal anti-VEGFs, PRP, and endocyclophotocoagulation. But all these are different tools which are available with the physician. And physician takes a decision keeping in mind the situation, current situation. What is the vision of the patient? That is very important. He has vision potential. How much the prognosis, how much he can get after the vision. So he has to taper and customize his treatment with the help of these different gadgets and tools which are available with him to manage the neovascular glaucoma. Number two thing is to control any systemic disease. If there are systemic disease causes, they have to be controlled. Very important. As I mentioned earlier, sometimes vasculitis and other factors are also contributing, so they should be controlled. And the control of intraocular pressure, you can use topical beta blockers, alpha agonists. Better to avoid prostaglandin analogs, better to avoid it, and also myotic drops, pilocarpine should be avoided. These are the conditions where atropine eye drops will be removed to control the help in the inflammation and maintain the blood-aqueous barrier. Yes, and the inflammation has to be controlled because the eye is red, inflamed. So we also need the help of the topical corticosteroid drops frequently, and then once the situation gets controlled, they can be tapered off. So these are the basic three targets which should be kept in the mind of a physician to control the ischemia, keeping in mind the condition of the patient, and then he can use whatever the treatment modality he wants. And the two other supportive I mentioned, that is to control the inflammation and control the intraocular pressure. We talk about the surgical treatments. We can do trabeculectomy with mitomycin C, or we can go for the glaucoma drainage devices. These both have the comparable results provided PRP is done before. Yes. Glaucoma drainage devices, we have Ahmed valve, Monzino, Berwelt. These all are available, valved and non-valved. They are basically used in those where we have persistent blood vessels. Yes, where we have persistent blood vessels and where other filtering surgeries are not possible, advanced stages, we can use these maneuvers. Valved one are better. Ahmed valve is better because there will be relatively less chances of hypotony. So these are devices available to control the intraocular pressure in such challenging cases. If the patient is blind eye or media is not clear and the prognosis is not good, we have to control the pressure, we have to control the pain. Then we have other cyclodestructive procedures. We can do CPC with anterior retinal cryo, cyclophotocoagulation. These things can actually cause sometimes hyphema, chronic iritis, corneal edema, and if you do CPC extensive, more than 180 degrees you cross, or even sometimes 180 degrees, there are chances of developing hypotony and ultimately phthisis bulbi. So these are some challenges with these treatments.